be admitted. Admitting all. Okay, and good afternoon, everybody. This is Dominic with the New Mexico Department of Health, and we are here to help and assist with regard to today's committee meeting, which is the Equity and Access Committee, with DezBaa as the chair. And while people are joining into the meeting, we'll give them just a minute or two. And in the meantime, just as a reminder, we do have everybody on mute, and other than some department staff and DezBaa as the chair, we do not have the cameras turned on. And the reason why we do that is, one, because we do record these meetings and put them up publicly, they have to get reviewed. And we want to make sure that there are no inappropriate language or images in the background. The other reason for why we don't keep all of our cameras on, and in fact, in a moment after the introductions, you'll see me turn my camera off except when I'm speaking, is mostly because we understand that there are areas of the state where bandwidth when people are connecting to the internet is not as good as we would like. And so in order to help people not drop off and have to rejoin at least any more than they need to, we try to reduce that bandwidth, and the visual side actually adds to the bandwidth quite a bit. And so with that in mind, I will turn this on over to DezBaa. And DezBaa, the meeting is all yours. I will go ahead, put the agenda into the chat.
So Yate, hi, good afternoon. Welcome back. I know some of you might have been going to some other meetings that we've had. I can barely remember what day it is or the time, but we are back from the legislative session. For those of you who have been keeping up with things, a couple of announcements. I do have an agenda that I'm trying to follow. So we are still awaiting MLG, our governor, to sign the equity fund money that Senator Jeff Steinborn was able to secure. It was about $630,000, I believe. And she has until today, technically, I guess, 11/59/59 to sign off on that, the money. So that is one of the things that we are, oh, she just signed. Awesome. Thank you, Denali, for that update. Yay. So that is the money that we're going to have to figure out how it is going to be spent and or distributed through the patient model for the medical psilocybin trials that we are approving and regulating, et cetera, for the future, that will be starting, I believe, next year, January 1. Is that right? And so that's one of the things. And then also as well, on the native tribal side of things, we are still looking at trying to gather all of the governors who were just recently elected in January, and making it more of a formal gathering to get input, and at least just to start having that conversation. For some people who may not be familiar, the tribal governance nations, they are sovereign. It's essentially like having our own country within the state of New Mexico, within the United States of America. So they have their own governance, how they deal with things, how they do things, even within the borders of New Mexico and the United States. So having that relationship, having that right relationship is really important. The governors change every year, so that's also another added challenge, or making sure that everything between Fed, government, and communities is taken care of. So those are just kind of the really updates. And with that, we're going to me, that's essentially the updates that we have. Oh, one more thing that was not put on the agenda, which I just recently learned, which is not exactly specific to the medical psilocybin, but just to put it on people's radar. Recently, Native Americans were able to gain access for their healing ceremonies through Medicaid, thanks to one of our cohorts, in part to one of our cohorts, Elena Dancis. Sorry, my brain is not helping me today. But if you haven't seen the article, there is one in Santa Fe, New Mexico regarding that. It's really important. I think that's also perhaps one of the points of information that we could be looking at, because access and equity through Medicaid, what those models look like, having that be something that we know that psilocybin psychedelics in general are a part of traditional healing pathways for Native people and their and cultural practices. So who knows if there will be a potential New Mexico medical covers traditional Native healing ceremony. So I'm not quite exactly sure all about that, but I think it's something that would be really important for our committee to look into, if there is already something in place and how that's going to be accessible with the medical psilocybin, if at all. So with that, we're going to go ahead and go into our PowerPoint presentation to review our purpose. Let's see, let's go in here to sign up for updates. Okay. Oh, we don't have it in this one. But can we pull that up or somewhere?
Yeah,
Sorry.
I'm
Dominic.
grabbing it. I'm grabbing it right now so that we can have that
Okay.
one.
Yeah, just to be able to review the purpose and the responsibilities of what this committee is. So far in the past meetings, it's mostly just been trying to understand the landscape of the different concerns. We have been hearing people from Oregon, we have been hearing people from Colorado, we have been hearing from people in New York. We are open to information and input from other people in other states and how that can potentially affect and or work with New Mexico's citizens. New Mexico citizens are the priority for this particular board and the committees. And so we're looking at other ways in which Oregon has seen challenges, or other ways in which Colorado has seen challenges, or information that is coming in from New York. We have had lawyers bringing in information. We have propagation specialists. We have also had facilitators out of state and also within state talking about the things that they see that are important as far as providing equity and access on both sides. To me, that is both the facilitator, propagation, and patient sides of things. How are we able to have access for everyone? Okay. And do we have the purpose and I'm sorry. There it is. Okay, got it.
Yeah, I'm trying to bring it on up. It's just I just had the PowerPoint up and then it dropped off on me. So give me just a moment. I'm getting it back up there.
Okay, so while you're doing that, I will go ahead and read the purpose and responsibilities. Purpose is to ensure that New Mexico's medical psilocybin services system is accessible, culturally appropriate, responsive to the needs of indigenous, rural, frontier, Hispanic. Should there be another comma in there? Indigenous, comma, rural, or is it indigenous, rural? Frontier, Hispanic, and underserved communities, and the program implementation that promotes equity, inclusion, and culturally grounded care across all settings. So that's a mouthful for sure. And the responsibilities are recommend to the board policies to expand access to rural, frontier, and underserved areas in New Mexico, including but not limited to telehealth, enabled screening, and rural training. Telehealth was something that was brought up initially in one of the first meetings. That is a model that can be used as a recommendation to the board, and what that looks like. Also recommend anti-discrimination and anti-stigma policies within the psilocybin services system. recommend policies that ensure culturally appropriate practices for Indigenous and Hispanic communities, recommend qualifications and process for determination for eligibility of financial assistance through the Patient Equity Fund. So number 4, as we said, is the first step of that is MLG signing that, and she did today, and learning how we, the board, or the recommendations to the administration of the Department of Health can provide assistance to these people, to the people that need it the most, which is making sure that we have equity amongst New Mexicans. And then also too, even though it's within the language of this paper, this presentation that's in front of you, is how the equity access is intersecting with all the other committees. For instance, propagation, that we are able to have access for everyone, whether it's at the financial cost level, we have testing that's involved. Are we allowing our New Mexican growers to be able to have access within reason to being able to provide their medicine for New Mexican citizens, as well as is the training that we are allowing, whether permitting and regulating, licensing, etc. Is that also cost prohibitive, or is it being able to people to be able to afford to train and to renew licenses or permits, and or how does that look? What kinds of training are we looking at? And is it thousands of dollars? Yes, you're investing in yourself and you're investing in the future of care of people, but it could potentially be cost prohibitive to some people, and we're trying to make sure to find that the intersection of that. Let's see. Okay, so to move on from looking at the purpose and the responsibilities, it is important that we figure out how and for whom that we're going to create the policies to expand access to rural, frontier, underserved areas in New Mexico, including but not limited to telehealth and enabled screening and rural training. This is where it gets a little bit nuanced, I guess. The only other, for those who may not be familiar with what this is asking, and this is my understanding, is in comparison to, say, the film industry. And I've used this example before. What does rural look like? What is the epicenter, the central point, and what that radius is expanding from? For instance, in the film industry, when it comes to figuring out where rural is, whether it's in Santa Fe or in Albuquerque, that mile radius will either include or exclude certain cities or towns. In the case of Las Cruces, it's considered rural, but that is, to a lot of people, misleading because it's a big town, right? So these are the things, that's the example I'm going to give. Those are the things that we have to kind of look at. What does it mean to be rural? And where are we looking at this radius to include or exclude some people? Are we looking at big towns? What does that look like? So I've also used the example of different communities culturally. Farmington area, which is a border town, Gallup also, which is a border town. They are bordering Navajo Nation. Their needs and what their care plan or how they're going to be providing access for their community might look different than what, say, is happening in Las Cruces, Roswell, Los Alamos, Santa Fe, Española, Raton, Clayton, or Portales. And what we're supposed to be doing as far as the equity and access and cultural considerations is trying to find somewhere that is not necessarily cookie cutter, but standard baseline, so that we can make sure that we are covering as many people as possible, not excluding people, but also understanding, for instance, in the case of tribal governance, that they have sovereignty, that they are able to choose for themselves in their community. What I am thinking is a lot of it is education, but even education is broad term. What does that actually really look like? What are these definitions? How is this going to actually be implemented? And that's where we need people who are on the ground actually in these communities talking about things that they are seeing that they need. I know that we had one lawyer from Mora, or that was representing in Las Vegas and Mora, the telehealth idea. When it comes especially to psilocybin and its use, there are different stages where we are evaluating a patient's needs and what would those assessing the patient's needs, but what do those God, someone help me here with presenting. I promise this is the thing that I've been dealing with like for the last few months. Their diagnoses, what do they look like, and who is going to be serviced with whatever diagnosis they might have, whether it's PTSD. Are we including domestic violence cases? Are we including other mental health issues? Are we excluding some where, if diagnosed by a doctor, that they feel that medical psilocybin may not be advised for use? In the case of, and I'm just throwing something out here, schizophrenia, for instance, maybe that might be something that is not advised. But in the case of a PTSD or complex PTSD diagnosis as such, we are also, if anyone is interested in those types of things, there are also committees for patient care in finding out what those presenting symptoms are, and where medical psilocybin would be advised. But what those look like, and we need to finding where those are being implemented in addition to the communities that might need it the most, and what does that look like. And in this example, I'm going to say, I think Rio Arriba, Taos County, and I think Santa Fe County most recently, as of I think the beginning of 2025, they had higher incidences of fentanyl overdoses. Those three counties specifically, for instance, they may have the data that presents that would be where the equity fund might provide more of the money. I'm not saying that this is the case, that this is an example. But then what does that look like, say, for instances of Roswell County, or especially, like I said, border towns such as Farmington and Gallup? So people who are on the ground, we do definitely need your input, where these instances we're going to need the most screenings for the demonstrated need to implement the equity fund and what that looks like. So it's defining things for whom. That's what it is when we're saying, like, for whom is the money going to be spent? Which particular areas may seem like they are the most in need? And or are we going to, say, for instance, allowing specific places to, of their own agency, decide whom of their patients might need financial funding for them specifically? So is it like a clinic that's in some of the clinics that are in Rio Arriba County? Are they some of the clinics that are in Taos County and also here in Santa Fe County? We also don't want to, again, like I said, leave out any of the more rural populations, what that looks like. So now that I'm done talking, I haven't seen if there's anything in the chat. Is there anything in the chat that I need to look at?
No, DezBaa, not at this point, but what I would recommend is that we see if people have ideas with regard to for the first portion, with regard to like telehealth and how to reach rural areas.
Yeah. So does anybody have anyone in the chat?
Okay, Dr. Linda Fatimi, I am allowing your mic. Sorry, I'm having a little issue with it. We're trying to allow your mic. I apologize. Okay, it is open. You may unmute yourself, Dr. Linda Fatimi.
Thank you so much. And it's Lida Fatemi. I know it's an unusual name, and I have my son in the background you're going to hear as well. But I want to thank you so much for the considerations you brought up, DezBaa, and the committee. Yes, Mama. Regarding telehealth, I see that being utilized, especially when we're in training individuals, training medical providers in the rural areas. You know, right now we have an addiction specialist, NP, down in Silver City who's training with us. And I see her being that spot point of community healing for her community of patients. For telehealth, I can see microdosing being able for us to be able to utilize microdosing. Macrodosing, I don't advise it to be utilized through telehealth. And I'm gonna stop there because my little one is not letting me continue. Sorry.
Thank you for your input. And I think there is, if Dominic, I don't know if you wanted to go ahead and bring it up. It's a little ways far back. IN did provide a possible proposal back in the draft section of the dashboard. And as far as what we were thinking with the telemedicine for preparation sessions, and yes?
Oh, no, go ahead, DezBaa. You just started launching into it, so go ahead.
Okay, yeah. This is just a proposal. I'll go ahead and read through it. It says, you know, New Mexico continues to experience a critical shortage of licensed medical and behavioral health providers, particularly in rural frontier communities. Residents of rural New Mexico face persistent barriers to timely, affordable, geographically accessible healthcare services. Telemedicine has demonstrated to expand access to medical and behavioral health care, improve community of care, continuity of care, and mitigate provider shortages in underserved areas. Equitable access to emerging and regulated
Oh,
therapies.
sorry, that's what I was doing. I wasn't expecting us to go.
Equitable access to emerging and regulated therapies, including psilocybin services, requires flexible delivery models that accommodate geographic and workforce limitations. This is more of a whereas proposal. That the proposal is that for the equity purposes, the committee recommends the Dosage Administration and Clinical Practice Committee that telemedicine services defined below are for preparation sessions. To kind of put people back up to speed a little bit, it was, I think, in the first committee meeting that this was brought up about utilizing telehealth. I think telehealth was something that was already provided through Medicaid. Dominic can correct me if I got that wrong. And in through utilizing telehealth within the Medicaid insurance system, I don't know if it's through all insurances, that at least the preparation sessions could be provided with a facilitator. It was strongly suggested that it would be for the preparation sessions only, as we are dealing with a medicine that has the component. We don't know how much of a dosage, even in microdosing, to some people may be something that needs a one-on-one, in-person facilitation. So the facilitation part of it is where we kind of thought about drawing a line with the telehealth at this point. So I'll read the telemedicine service requirements. The service must meet the following requirements: include audio and visual, be delivered on a real-time basis at the originating and distant site. No restrictions on services that can be offered via telehealth. And by that, I believe it means, as far as the assessment, no restrictions on the telehealth. It could be anything that's presented. If the provider resides outside of New Mexico, on this part, I'm not sure. This one seems to be worded a little bit weirdly. Meet the following requirement: if provider resides out of New Mexico, is licensed to provide services in their respective state. Okay, got it. Okay, so this is for the facilitator. If the provider resides outside of New Mexico, say they're in Colorado or Oregon, they have their licensing there, that they're licensed to provide psilocybin services within their respective state and completed a New Mexico specific training program. This one I will kind of highlight to bring attention to. I'm not sure quite exactly. I feel like that one might need to be evaluated and looked into, for my personal thought. If there's anyone who is in the meeting would like to pipe up about any of the things that were read, or any other further thoughts or conversation on this particular proposal to the board, in agreement with this or not.
DezBaa, we do have a couple of hands up. The first one is Denali.
Okay.
Denali, you can unmute yourself.
Hi. This is helpful. It was a little hard to follow just because we can't see the proposal, but maybe it can be shared some other another way. I'll just mention, I think I understand the policy restriction for non-administration days, but I do think it would makes sense to also include authorization for integration in addition to preparation. So if we're wanting to restrict the in-person days to administration for therapeutic doses, I don't think we need to exclude integration, but would like to hear other thoughts, especially from the providers who are on the line, about whether there is a need to have that happen in person.
So Denali, just to let you know, I did put it in the chat, so that you can actually read it there in the chat. No, that's okay. But the other thing too is this was just an initial item from Ian. He wasn't meaning it to necessarily restrict in other aspects of the therapeutic side, just the administration aspect like DezBaa was talking about. So this is just an example for how it might be with regard to preparation sessions. But it's really good to hear the feedback of it being included for those other therapeutic aspects as well. So definitely thank you on that.
Dr. Fantini, you may unmute yourself.
Thank you. I agree with Denali and Dominic. Yes, integration can absolutely be done through telehealth as well. I, in general, like the proposal that you read, DezBaa. One comment is about facilitators in other states serving our individuals in our state. Though I'm for it if we don't have enough facilitators in our state. I would say that should be a secondary thing, where the facilitators in our state, where also the contributions back into our land and into our community and people would be important economically for facilitators who are on the ground, know this population, know our community, know our indigenous and cultural needs, to be the facilitators that maybe get the first go. And then we look at if we are lacking facilitators here, to then go out of state. That's the only other comment I had. Thank you.
Yeah, and then to both of those 2 points, that this was definitely for the preparation sessions, like the initial evaluation sessions, but it is very good to put a note that telehealth would be also potentially advisable and or not would be beneficial for the integration sessions. So it's still valuable feedback, both from Denali and Dr. Fatemi, for that. And I do feel like that is another highlight for this potential proposal, is just the idea of outside. And this was like back like 3 months ago that I got this particular piece of information. I just wanted to make sure that we are looking at things like this. And this is good. We don't have to play nice sometimes with our opinions about, it needs to be for New Mexicans, by New Mexicans. Totally, that's a great recommendation, to have a strong recommendation that it's by New Mexicans, for New Mexicans. Totally on board with anybody who has a stronger opinion, but also willing to listen to this idea that we are going to be have a little bit more open borders, and who knows, it may not even be able to work out that way, as far as who we are allowing to be able to provide for New Mexicans. But I think, to Dr. Fatemi's point, if initially or at some point where there are none, there's just like this influx, maybe that might be a good, circling back to, in the case of like, what would we do if everybody is so booked up that they have no more appointments available, and someone really needs to have that care. And especially, for instance, let's just say, I'm not sure exactly why that was put in there, but I'm just thinking like Farmington, Kirtland, any of those places where you are right across the border. Maybe there is somebody that you have a good relationship with, and it might be that case where you have a relationship with someone who is not necessarily in New Mexico, and maybe that would, why can't they choose someone that they trust? I can imagine. I think that there is a question in the chat. If we could go ahead and address that. Did anyone already read through it before I mean, I can read through it, but.
Yeah, DezBaa, we haven't actually read it, but I was actually working on a response in the chat. So
Okay.
I'll go ahead, and this is the one from Kenny, I'm sorry, Kaina. I apologize if I am completely mispronouncing your name. My apologies, but it was about the question that came up during research and continuous improvement, and just really talking about race being an issue, and about whether or not an individual had previously used psychedelics, and what the clinician benefits are with regard to having that information during the screening process. And then the question that it brings, potentially significant, stronger emotional responses for people of color who are under greater scrutiny and at higher risks for prosecution. And discussing about, while it's a legal medical program, the concern is that a question about prior use may be alienating for those in BIPOC communities, for folks of color on this committee. Is it a question, prior use, perhaps legal, but quite possibly underground, and one that could have the potential to prevent those individuals to utilize care? And one thing to remember is there is also going to be a big difference in many ways between the research aspects, where people are choosing to be in those research areas, and the medical aspect of the program. So someone going in for treatment. And for example, someone going in simply for the treatment aspects, the program, for example, is not going to be gathering or containing all of that information as far as prior use. We're going to really be looking at, has the clinician done their due diligence with the patient and do they recommend and attest that this patient would actually benefit from treatment? And so that's a great question, and it's one that we've been talking about quite a bit as far as what could potentially be problematic as far as questions to be asked. And I think some of it is there's that balance between people wanting to gather as much information as possible because these are new programs and we need that research side, as well as balancing it with the needs of the patient and those potential issues with regard to legality, prosecution, those sort of things. Don't have exact answers yet as what that balance will be, but that's a part of this concern and a part of this process is going through it. I do see that Denali does have her hand up again. Denali?
Hi again. I just wanted to offer making sure that the therapy parts are included in telehealth feels important. I'm trying to remember back to, I think it was Brett's initial contributions around telehealth. But I do think there was a conversation then around whether, and I heard it in Dr. Fatemi's initial comment around the potential of microdosing, right? Not every dose is a behavioral health heroic dose, right? And especially even if we're not talking about microdosing, but pain protocols that are much lower doses, it's not a qualifying condition now, but we want to make regulations that that are evergreen, right? That are as expansive as they can be. I'm wondering whether maybe it makes sense for rather than a full preclusion of administration and telehealth, certain safety requirements, including a dosage threshold. I know logistically it will be there are a number of different challenges to move through, but if we're talking about small doses, one of the things that has diverted a lot of microdoses and lower doses, and especially pain patients, from the regulated market to or the regulated space in Oregon and Colorado is inaccessibility because of the in-person requirements that really, from a safety perspective, aren't as necessary, though they are tremendously necessary from a behavioral, if we're talking about a therapeutic dose. It just really, the care is different. So I know we're just having an exploratory conversation now, but I didn't want to endorse the full exclusion of administration, but thinking about creative ways we might be able to infuse safety, if that is a dosage threshold and other parameters, making sure that there is someone else with someone that can be vetted, right? This gets connected to homebound use and those kinds of things. So as long as we're keeping the conversation open, I'm grateful to know that we're prioritizing telehealth and accessibility.
Okay, so from what I'm hearing, from what you're saying, Denali, essentially is, maybe putting a pin in this idea of what does the dosage look like when it comes to the telehealth assessment portion. And I think that we could probably break up the telehealth portion into, say, 3 different sessions, right? You have the evaluation session, you have a potential for a journey, let's just call it journey session, and then you have the telehealth for a integration session, right? And so what I'm hearing from you is that taking a look at the journey portion based on an assessment of the need of the person, whether or not the facilitator may or may not advise a microdose. And that microdose may or may not be X 0.1 grams, et cetera, whatever is based on the dosage committee recommendations, that might be okay, given that there are parameters and or something. That's kind of what I'm hearing from you, is that during the quote journey portion of a potential telehealth facilitation, that the dosage committee might look into what does a microdose look like for telehealth during a journey session in a rural environment with certain parameters enabled, with access to doctors, or, you know, like what are the lifelines that are involved during that journey process is what I'm hearing, Denali, essentially. Do you have a thumbs up or?
Yeah. But you've got it. And I see
Okay.
Dr. Fatemi wants to chime in too. I just like, if we think about a migraine protocol, for example, right, which is like 1 gram every week for 3 weeks, I could imagine as we create a safety mechanism where for the first one, say someone lives in a rural community, we're requiring somebody to come in for the first session and have in-person facilitation to see and monitor how they do. But it will become really cost prohibitive if we require that travel, especially for someone suffering from chronic pain. And there may be, right, I'm not the clinician here, and I do want to hear from clinicians, but in a right, where I wouldn't call it the journey day, because the idea is that there's not really journeying that's happening. That's what allows for the safety of a potential remote supervision. But if that's possible, we want to be sure. I'm really thinking about pain protocols and ways that might be possible.
Okay. Yeah, and I forgive me for not using proper terminology. We're still kind of figuring out what the definitions are. So my definition of the journey was just like you popped the pill or whatever, you've taken the mushroom, you're eating it, you know, one with the mushroom. And just to kind of point out for anyone else who's listening, do understand that 1 gram of any specific cultivation or cultivator, it can potentially be totally different than a gram of a different cultivator. And we're also keeping that in mind, as if anyone is involved in the propagation committees, they are looking at opening it up to any number of cultivators for the program as a recommendation. These are all recommendations. Nothing is put into existence in writing yet. This is all we're just thinking about. What does this look like? So that is one of the things to keep in mind. So 1 gram could be completely fine on a specific cultivator. 1 gram might be like you're off into the clouds on a different cultivator. So we also have to kind of keep those things in mind when we're talking about what does a microdose look like. Okay, and then so those are good, valid points, and I hear that you're saying that's very specific with the symptoms that are presenting and the evaluations based on the facilitator, et cetera. Dr. Fatemi?
Yes, thank you so much. And yeah, I love the points you're bringing up, Denali and DezBaa. So the microdoses that, I've utilized in the past, we're talking like 50 milligrams in a coaching session on Zoom or on FaceTime, or in a space where the patient has access to it, or the client. And so in those therapeutic sessions that is through telehealth, what I've seen is a greater availability of the person to their subconscious, so they can explore their trauma in an observer seat, instead of being so involved in that resistance of, and fear of examination. And we're talking very small doses, and I'm not just talking about, I'm talking more in the realm of the behavioral health coaching and therapeutic session with the individual on the telehealth container, with those very small doses, which they don't need to go to a center for. And yeah, I do agree with you, Denali, that 1 gram can be a lot for some people, and that should be with someone. And yeah, it could be cost prohibitive for the subsequent. But yeah, we have to, these are things that it's great to be talking about and coming up with recommendations. But I've seen incredible work done with within a therapeutic session, whether that's, again, a coaching session, whether that's a therapy session where you also have CBT type thing that is integrated, and a very small amount, again, 50 milligrams or maybe 100 milligrams of psilocybin is also taken together, no more than that. And that is, we know across through and through, that is the sub-perceptive dose. And I have not heard of, I mean, I've done this for, many years now, and have not seen anyone, even with extreme trauma or, very little trauma, to have any adverse reaction to 50 milligrams. And so that's minuscule, and in fact, when I give talks at psychedelic conferences about this and the results that we're seeing for clients, that people in the psychedelic community are like, what, you're using that little of a dose and seeing this kind of a result, reminding us that it is that deep connection of care and compassion of the facilitator. And I'm not meaning in a macrodose session, but that catalyst, the individual who's sitting for the person across that televisit or in person with that tiny dose, and also how much we care about that person. We know psychologically that makes a huge difference. And secondly, showing people and giving them tools, our patients and clients in the community, how they can make themselves feel better as well, with breath work, with meditation, and many other tools that there are. And that's a very empowering thing when combined with a very, very low dose
Yeah.
psilocybin.
Yeah, so
thank you.
Yeah, no, thank you for your insight into this. What I'm hearing from both Denali and Dr. Fatemi is a recommendation to talk about it with the board, with the dosage committee is input, is providing a telehealth with consideration for whatever they consider a microdose, is essentially what I'm hearing, as far as, don't overlook it, don't leave it out. Telemedicine may or may not be potentially advised with whatever the dosage committee sees is a microdose and or less. That's what I'm hearing, because there are benefits perhaps to the access for people in rural areas, and or it may be financially restrictive, or the in-person portion of it may or may not be restrictive. That's what I'm hearing. If there's anybody else that has something to say in the comments, or to raise their hand if they agree to that assessment of what I'm hearing. We have like about 10-15-ish minutes left in our meeting here, and I just wanted to not leave anybody else out. Okay, so that's the thumbs up from Dr. Fatemi. Okay. Yeah, I think that we're kind of, this might be a little bit slow moving, but that is going to be a note in the telemedicine for lack of a better way of explaining it, is the journey portion of after the assessment, and mainly for pain, for things, an example, for symptoms such as pain, such as migraines. Okay, just to make sure I have a note in there. Just gonna, let's see. I feel like we have kind of looked at this idea of telehealth. There's probably way more to talk about with that, but I'm going to go back to the agenda really quickly. Let's see. We also have enabled screening and rural training to look at. Enabled screening and rural training. All right.
So DezBaa, it's actually telehealth enabled screening, so that, for example, the clinician who is helping to do some evaluations on, for example, treatment-resistant depression, might be able to do some aspects through telehealth. But if I may, just because we don't have a lot of time, it would be really great to hear from everybody, because we're going to start writing out some of the ideas behind what needs to happen with regard to the Patient Equity Fund. And since we only have a few minutes left, if maybe we could spend a few minutes just hearing from people that, other than financial assistance, because we recognize looking at things from whether it's ends up being 200, 300, or whatever it might be as far as percent of income based on the federal poverty level, that we recognize that there's going to be assistance from that side. But what other areas are people going to need assistance that could be provided through the equity fund to help them and facilitate the treatment? Now, I know we've talked also about transportation for individuals who are in rural frontier areas to be able to get to appointments, things like that. But what other areas are there that we need to look at to ensure that access for the equity fund?
Yes. Besides financial and transportation, are there other aspects?
Yeah, what do interpreters? Thank you, Catherine. That's a very good one. So interpreters, child and elder care. So if someone's going through their treatment, there's also child care or elder care provided. Okay. And people can raise their hands too if they have other ideas. But these are great because this is exactly the kind of thing we're trying to figure out. And it's always great to have a group of minds rather than just one or two.
Yeah, and I definitely, as a mom, the child care aspect is definitely a huge one, and especially when you're looking at people in my age bracket, we're not only taking care of the little ones, we're also taking care of the older ones as well. And so we need to make sure that we are providing the support that people need, both during the sessions that are required. I mean, these sessions, journey sessions specifically, for instance, could last several hours, and you may not be able to find the time while the child is in school, or someone is taking care of, like, your elder. So Dr. Fatemi.
Thank you. And I might have missed this part, Dominic. You might have said it already. Sorry about that if I'm repeating. But the question that I have is, are we also talking about the therapeutic sessions themselves? Are we talking about the preparatory sessions? Because sometimes that takes a month or two of sessions, and also the integration sessions afterwards takes a month or two, depending on the severity of the trauma in the past and so forth. Is that a part of the discussion here for the equity fund? Yeah,
it's anything that having some of that financial assistance could help someone, like if it would be a difference between an individual receiving treatment and therapy or not receiving it, and it covers the entire span. It's not just the day of administration. It can include some of those others. So
yeah, gotcha. Yeah, and oftentimes that's what we see that's being so expensive too. It's, if you look at, like, therapists, depending on their experience, years of experience, it's $150 to $300 an hour to sit with a therapist. And if you need 4 sessions or 8 sessions of preparation work beforehand, or 4 sessions or 8 sessions after the the macrodose, this is what we're talking about, macrodose specifically, then that I can see be very cost prohibitive, and individuals will absolutely need financial assistance there.
Yeah, and then kind of, I'm going just based off of the comment that's in the chat. Things to kind of also look at is, I mean, 600 and I'm not sure exactly how the government looks at $630, but given how things are costing a lot of money nowadays, it's a great amount of money, but it's also, like, it's limited at this point, right? So we also have to kind of look at we don't want to have to look at, but have to look at, you know, how many sessions there are. Is this going to be, you know, for all covering all 3 sessions, that sort of thing. I don't know, Dominic, you know, to me, those are the kinds of things that we also looking at, because one person may need, you know, it's like a one and I want to say a one and done, right? It may be a one and done. It could be that this is an ongoing thing. Generally speaking, I think a lot of people are essentially one and done. You know, they have immense benefits after like one really big session, but we also need to have the possibility of what does it look like for future sessions if this is something that is going to be drawn out for, you know, divvied up between several different lower doses, for instance. I have no idea what that looks like, you know, and what that might be advised between the facilitator and the patient. But I think even nuanced things like that, is that correct, Dominic? We're like looking at what does it look like, not just across the board. You know, are we cutting some of these things in half? Are we paying for half of the dose? Are we paying for half of the session? Are we paying for all of it?
So again, some of that's going to depend on financial abilities of the individuals, because again, this is about equity and access. So it doesn't necessarily mean that the equity fund would pay for everyone. If we did that, quite frankly, we might be able to actually help fund maybe only a couple hundred individuals. And so, especially as there's some great comments in the chat and we're making note of them. So if we're not responding right away to them, please understand we are taking notes on them. But the idea is that we, you know, that we be able to actually spread this out among as many different people as possible to ensure that there's equity on it. And so some of it's going to depend on what the patient themselves might be able to pay. For example, you know, we want to make sure that individuals who have lower income are able to access this treatment, just like people who otherwise, and we've heard this a lot, that, you know, people who can access this therapy in Oregon and Colorado have money. So we want to ensure individuals who do not have money are also able to access this based upon the need. But we are going to have to figure out what kind of areas there are. So it may be sliding scale, depending on various factors. Like maybe on transport, there's only so much that we can help cover, and maybe we can cover all of it if someone is, say, below the poverty level. But those are some things that we have to figure out, and it's going to take us time to adjust. But this is why we wanted to hear about these other aspects, like, you know, some of these things about helping the support in the community, you know, the comment about having some of that potential support for a family or community. It's not just about the patient themselves, you know, it's really the whole community is the patient. And so that entire support structure. So how might we be able to help for that? And so it's really looking at those different things with that caveat that if we were to try to cover everything for everyone, $630,000 for a year is not going to go very far. So how do we do this the best way possible? So these are all great ideas, and we'll definitely have a lot more conversations about them and trying to figure it out. Catherine, I just saw yours about the computers. That's a great potential, you know, concern and potential issue, because libraries are really great as far as that, or community centers, because they have computers, but they're not very private. So how many people want to go and start talking about, you know, their interpersonal thoughts and ideas and concerns while sitting in a computer lab in a library, or, you know, things like that. So how could we help with regard to that even a little bit more? Maybe it's about helping to figure out how to fund private rooms or private locations or things like that. And so we have to figure, there's a lot to determine, and how do we do this? And so these are great ideas, and they're going to help us. And in this committee, as we bring them back, because what we're going to kind of do, our next step is we're going to take some of these ideas, and Jorge and myself and some of the other members of the team, and work with DezBaa in order to sort of say, okay, here are some ideas. Here are some of the things we're hearing. So with that, I know we only have a couple minutes left, DezBaa, and I think we've heard some really great comments. Are there other items we need to cover, or and by the way, if people think of things outside of this, you can send them to us. They don't necessarily just have to be part of public comment, but I'm going to put the information for the public comment in the chat as well. I've got it on the screen right now, because you could still send it to us, even if you're past the public comment for the meeting, and we will do our best to add it into the different discussions. So
Yes, thank you. So we do have to wrap it up because we collectively have to get to the other committee that is propagation later on to hybrid. If you're interested in that, it's with Chris Piskuski at 3, I believe. So, you know, for me, I always break down numbers, and I'm just, you know, I'm not saying that this is the thing, but when we're looking at $630,000 divided by the day for an entire year, right? 365 days. And I hope next year is not a leap year. It's it's a 1,700, it's not even 2,000 a day, right? And I think, Dominic, what I'm also hearing too is like, it also depends how many patients we're looking to be able to take care of, let's just say take care of, in this medical trial for the year, and what are the costs added up based on the let's just say fair market value of the facilitators, the cost of propagating, the cost of the testing, and everything else adds up. And I probably would assume that that's more than $2,000 a day for all of that, right? So all of that fair market value for the facilitators, for the transportation, for the medicine itself. And if we were using Oregon and Colorado and New York prices, we're talking a lot of money for this one particular dose for this one person. And I think that just to kind of maybe think about it in those terms, like how are we going to maybe not necessarily reach everyone, because this is a medicine that may be possible for everyone if they're determined that it's good. And not everyone needs to take it, but for those who are qualifying, for those who are seeking it, for those New Mexicans who are willing to journey into this next part of their life, right? The amount of money that we have is limited. It's a great amount of money. Thank you very much, everyone, for appropriating that money, but it is very limited. And how are we going to be able to best utilize it for the most, I don't want to say neediest, but for those that are going to be moving forward with this next portion of New Mexico's into the future, right? Those people and the patient. How are we going to collectively say, these are the people that we're going to work with, this is how much we're going to allocate, and what does it look like for the cost? So with that in mind, you know, if you have any other broad ideas of what it looks like, it could be like, you know, Dominic was saying, like a sliding scale. Are we looking? And then also not only that, but elder care, child care, et cetera. It does add up. And I'm thinking like just this number in my head is $10,000 for like one session, fair market value with whatever it is, gas prices now at $5. You know, it's going to be, it's a lot, but we can do this. We can figure out how would be best the money that we can spend for. And also to this, just really quickly, when we are able to help one person with this medicine, one person, imagine the impact that that may have for that person's family and for that person's community. And that value, that money value drops. And I say that in the sense that like, we're getting that member of that community back online. So with the limited amount of money we have financially, it will make a huge impact to that person's life. But we also have to really think about the financials with it. So, all right.
DezBaa, I think the only thing remaining is to determine the next meeting date.
Oh boy. Okay. Next meeting date. Let's see. Let's look up in the calendar. Not Wednesdays, that's for sure. There was a conflict today that I avoided. Let's see. 1, 2. We can potentially do the 23rd or the 24th. I'm not sure what the calendar is for the other.
We could schedule it for 1 o'clock on the 24th. That time is open from the department side.
Okay, let's do that. 24th on the 20th.
So we'll set it up for 1 p.m. on Tuesday, the 24th of March.
Okay.
Okay.
All right, so everyone put on their thinking caps and reach out to more people to join us. And thank you very much for your time today. Appreciate you all. Thank you, Jorge, and the administration. You are lovely assistants. I appreciate so much.
Thank you, DezBaa. Thank you for everybody for being here. And if you're going in person to the propagation meeting, we'll see you over there in about an hour. That's scheduled to start at 3 o'clock and is over at the Westside Community Center here in Albuquerque. So otherwise, we'll see everyone else on, I'm sure, on one of the other meetings. Thank you, everybody, for being here and helping.